All right, so some invasive tests that we have for veins. We have isotope venography, contrast venography. We have MR venography, CT venography, as well as a lung scan that's called a VQ scan, or ventilation quotient scan. And other invasive tests or procedures are also our arteriovenous fistulas, or AVF fistulas, which are used for hemodialysis access grafts. So the first type is an isotope venography. This is a nuclear medicine procedure. In this procedure, they inject iodine 125 into the veins. And this is good for detecting clots that are developing or actively developing. Can also be used to find isolated calf vein thrombus. The way this works is that isotope, it binds to fibrinogen, which is kind of like the clotting binding portion of a clot. So they inject the contrast, and then 24 hours later, they scan the patient and they look for increased radioactivity, which can indicate acute thrombus. Unfortunately, this isn't good for a clot that's already well established, and is kind of limited in its ability to detect like the extent of the occlusion. So this diagram, you see a normal right leg, complete perfusion, the black, going through. And then on the left leg, you see here in the thigh, you lose that contrast, that filling. So more common is what we do in the hospitals is the contrast venography. So this procedure will show both deep, superficial, and perforator veins. It's highly accurate. So what they do is they inject the contrast into a small superficial vein in the foot, and they allow the contrast to run up. It can also be used in the extremity of the arm. So the same process, they would go into a small superficial vein in the hand, and they take serial X-ray images, imaging the contrast as it slowly works its way up. So it's basically done in real time. So they're tracking this contrast as it moves through the veins, lighten up the veins. So you get an image in real time and you're able to track it and follow it. So this shows how the contrast venography, you're able to see even small little superficial collateral pathways. So this is an image of subclavian vein and shows some collateral pathways. So this is a venogram for the upper thigh. So you can see the deep femoral vein here, and then the femoral vein. You can see how you lose the contrast through this segment So this is what they consider a filling defect. There's no contrast filling in this segment. So that's indicative of a thrombosis or clot. So this contrast-based venography can be formed using two techniques, an ascending or a descending technique. So the ascending technique is what we use to assess for clots or DVT. So that ascending technique, the contrast is administered lower down, like in the hand or the foot, and we image it as it moves proximally. So it's the contrast, way I kind of remember the differentiation between the two is the contrast is ascending, it's going up. It's starting low down in the hand and working its way up the arm, or it's starting down in the foot and it's working its way up, and it's used to identify DVT or occlusion. It can also be used in a descending technique in order to evaluate for reflux or retrograde flow. So with that, they'll inject the contrast into a more proximal vein, like the common femoral vein, and they'll try and image the contrast flowing backwards through the valves in order to evaluate for insufficiency. So this just explains a little bit the procedure for the ascending venography. So you begin with the placement of catheter in a peripheral vein in the dorsum of the foot, top of the foot or top of the hand. Inject the contrast. And then they use X-ray, basically a fluoroscopy procedure, which is an X-ray, like in real time, to track the contrast as it moves through. So with the upper extremities, you keep the patient supine. With the lower extremities, they then tilt the patient up to almost a standing position, and they watch the contrast as it moves. So for descending venography, requires direct catheter access into the deep vein. In most cases, the access site is the common femoral vein on the contralateral site of interest. So what they do is they actually put the catheter into the common femoral vein, and then they run the catheter up to the IVC and then back down the iliacs to get to the other side of the leg. And then they start administering the contrast. This is for the descending venography. So for descending venography, they enter into the jugular vein in the neck. And they can also run that catheter down the jugular. So another imaging modality that we can use is MR. So it's the same principles. They'll inject the contrast and use contrast and track the contrast using MR. This is a little more difficult because you also have to time the contrast properly. And the use of MR is definitely more expensive than a CAT scan. And the process takes a little bit longer. Also, some patients may not be suitable for an MR due to pacemakers or defibrillators, or metallic implants. They may not be a good CAT. They're unable to do the magnetic imaging. But some of the benefits of using MR is you get a very detailed picture. So with CT venography, contrast materials injected intravenously, and they're placed into the CAT scan machines. Limitations for this: the vessel only seen best with contrast injection. It's more expensive than ultrasound. Sometimes patients can have adverse effects to the contrast. The CT is good for imaging iliac veins. So another test that's commonly performed in the hospital is something called a VQ scan, or a lung perfusion scan. So with this test, it's performed on patients that there's suspicion of pulmonary embolism. So it's a nuclear medicine procedure that's performed, and it shows blood circulation in the lungs, as well as how well the lungs are able to be ventilated or absorb air, like how well the lungs are filling with air, those alveoli, those air sacs, how well they're able to fill and how air is moving within the lungs. So the radioactive material is injected into the arm. Then images of lung perfusion are taken with patient in various positions. So the reason for that is they want to view all areas of the lung. And then the scans are interpreted as high, medium, moderate, or low probability for pulmonary embolism. So limitations for a VQ scan, it could potentially be non-specific. There are other disorders that can cause perfusion defects, like if a patient has COPD, if they have like asthma, other issues, like if they have emphysema. So they combine the perfusion scan with the ventilation scan to get a more accurate diagnosis. So these are some pictures of the VQ scan, the perfusion portion of it, showing, you know, the contrast or the radioisotope going perfusing throughout the entire area of the lung field. And they take it from different angles to view the entire lung. And then this is the ventilation portion of it, how well the air is moving within the lungs, and the air filling in the lungs. So then this shows some defects. So another test that we do in the hospital is the D-dimer assay. So this is a blood test that's performed. So D-dimer is a product of fibrin degradation or breakdown. So when the fibrin, and that's normally in our blood, forms into clots and it starts to break down, this D-dimer becomes elevated when clots are starting to break down. So a protein fragment is present in the blood after a thrombus is degraded by fibrolysis. So when the clots start breaking down in the body, they release this product or protein fragment, and it can be detected using this D-dimer test. So a blood test is to assess and evaluate if a patient has a thromboembolic event, such as a venous thromboembolism. The problem with this D-dimer assay test is other conditions can also raise your D-dimer. So things like recent surgery, trauma, infection. So under infection, you can actually put COVID. COVID is actually one of the main things that, for whatever reason, it raises people's D-dimers. Maybe it's the inflammatory aspect of it, but every patient that I've encountered that has COVID has an elevated D-dimer. So in the hospital setting, doctors are quick to order lower extremity and upper extremity duplex studies to rule out DVT based on this elevated D dimer. I mean, sometimes we find clots. Oftentimes it's still negative, but it's just the nature of the disease, you know, and we have to, you know, take all the precautions because unfortunately COVID does increase risks of developing thrombus as well. So if a patient, there's a certain level associated with the D dimer, so a negative D dimer would be below that level. There's no indication for DVT. A positive D dimer would be above a certain criteria, and it could indicate the potential for a patient having a DVT. So arteriovenous fistulas, AVFs. So we went into this a little bit last class with the vein mapping. So with an AVF, it could be intentional, like in terms for making a hemodialysis fistula, they intended to do this connection. So basically an AVF is a connection between the arterial and venous systems. So anytime you see AVF, it can be intentional or it can be potentially something that was done by mistake. For instance, if they went in to do an angiogram in the artery and they punctured too far into the artery and then they accidentally punctured into the vein. Because if you remember, like when we're doing our lower extremity Dopplers, usually the artery sits on top of that vein. Actually, I don't know. I guess you did lower extremity arterial studies. But sometimes they can puncture too far and then make like a connection into between the artery and the vein. That's not intended. Also, like if a patient, I know some of you DMS girls, like if you're scanning a uterus, and the patient is status post C-section, they've cut that uterus. Sometimes when they make the cuts, they can accidentally create something called an arteriovenous malformation, which looks like an AVF or is a type of AVF, where there's now a connection between the artery and the veins. And when you're scanning the uterus and you put color on the uterus, you'll see very intense blood flow because now you have arterial blood entering that venous circulation. So on duplex, you'll see in the arterial portion, increased velocities. You'll have high velocities that are low resistance, so a lot of diastolic flow. And the venous pattern now, since you have arterial blood entering the venous system, it's called mixed flow. So the venous pattern looks very turbulent. It's low resistant. It has high velocity. So here we go, types of AVFs. So congenital, so that can be that arteriovenous malformation, acquired through trauma, surgery, aneurysm rupture, catheterization, or it can be surgically created, like an intentional AVF. So ultrasound characteristics. So the high pressure arterial circulation is now shunted into the lower pressure venous circulation. So when we have that big difference of pressure, we're going to have fast velocities because there's going to be that high pressure gradient now, especially at that point of anastomosis or that connection between the two systems. So blood flow is now shunted into the venous system. So the arterial component will have increased flow velocity and decreased resistive indices, meaning you're going to have a high diastolic component. It's going to be low resistant. And the venous portion now is going to take on some pulsatility because now there's arterial blood mixing in with it. So you're getting some arterial signals within that venous flow. So it's not going to be that normal, nice flowing venous, like, you know, undulating waves. It's going to look a little more arterial. In addition, distal to where that connection is, you can have reduced arterial flow. And this is particularly important when we get into the surgically created hemodialysis accesses. So this is a picture showing the common femoral artery and the common femoral vein below it. And then you get this area here of ileocene. This is going to be that connection. So you have very turbulent flow within the vein. You get a lot of ileocene here in the vein. So this is probably a result of they tried doing a catheterization. They punctured the artery, went into the artery, but they may have gone too far and actually punctured into the vein. And due to the proximity between the two, now you have a connection. So you have blood flowing from the artery, the high resistance area, into the low resistance or low pressure area of the vein. So if you Doppler, right at that anastomosis, you're going to get very fast velocities, low resistance. And when you get into the vein now, it becomes this turbulent mixed signal. So it kind of looks arterial, but yet it kind of looks venous. It's a very unique waveform when you get into the vein. So when you're Dopplering the vein, if you're more proximal, like higher up in the leg, you could potentially see, you will see that fast velocities and that mixed signal. But if you're lower down in the leg, you may still have normal venous waveforms because the blood flow now is moving back up the leg. So it's, coming down the leg, it hits this area, gets shunted into the vein, and then starts returning back up towards the heart. So if this is our nice longitudinal images, this is the head on this side of the image, legs down here. So physiologic changes in an AVF. So you have increased proximal arterial flow. You have increased venous flow. So decreased distal arterial flow. So this refers to after that connection site further down in the peripheral arteries. When you get lower down, you'll have reduced flow within that artery because you're shunting that arterial flow. So that the flow that was in that normal artery now is getting directed into the vein, but you still have to maintain flow down the arm. It's decreased the volume. So you have decreased distal arterial flow. You have increased venous pressure now in the veins because you're now shunting all that arterial blood flow into the venous system. You also have to worry about stenosis at the venous anastomosis. So like where you have that connection with the vein, you look for stenosis. And you also have to worry about stenosis in the venous outflow. This is for the hemodialysis access grafts. You're always assessing for stenosis, and we're gonna also check for flow volumes. And other things you have to look for when you're evaluating an AVF is for aneurysmal dilatation, aneurysms, or pseudoaneurysms. So this is an example of like the arterial signal that you'll see in the artery prior to the anastomosis. You get that low resistance, high diastolic component with very fast velocities. So effects of an AVF, so the arteries. So the proximal segments near that anastomosis will dilate and elongate. In the venous sections, you may develop atherosclerosis, so you may now get some calcified plaque developing within that into the venous system. Now, typically you don't see atherosclerosis in the veins. It's an arterial issue, but now that you're introducing arterial blood into the system, atherosclerosis now becomes an issue in the veins. Oftentimes you'll see this with patients that have long-standing dialysis fistulas. They'll start developing some of that calcified plaque within the veins. Um, I oftentimes see aneurysmal segments for the veins too, so I would put aneurysmal under venous as well. Sometimes the veins could become very large and dilated and become aneurysmal. Again, the veins also dilate and elongate. All right, so this picture is showing the artery at Dopplered at 3 different sites. So if the blood flow is running, say this is the head, this is the leg, running in this direction. So this would be prior to the anastomosis. Have what looks like, you know, a normal low resistance arterial waveform. And then when you get to this anastomosis, you know, it becomes very fast and very turbulent. If you look at your velocities, you know, you're over 500. So that's really fast. You're starting to get like this mixed signal because you're introducing now, getting towards that into the venous system. So it's very turbulent. You have a lot of aliasing, spectral filling. And then after the anastomosis, you return back to what you would expect to be like a normal peripheral arterial waveform, you know, where it's, you got your fast upstroke and nice low diastolic component. So this is your more high resistant normal peripheral arterial waveform. So important to note too, when you get into scanning these dialysis fistulas, immediately after the anastomosis here or that connection, you can typically have retrograde flow because sometimes this anastomosis, it's so powerful, it's so strong, the velocity is coming through that it actually sucks some blood flow back in this direction. So if you Doppler immediately after that anastomosis, you'll find a Steele syndrome and retrograde flow. So you move down a little bit further and see if that still persists. If you're still getting retrograde flow further down, that could potentially be an issue. But you should return back to your normal arterial waveform as you move down the arm or down the leg. So again, your superficial veins of the upper extremity, you know, you have your cephalic vein, basilic vein, median antecubital vein. So hemodialysis access. So we do this with patients that are in chronic renal failure. I mean, we could also do it. I've seen it done in the hospital when patients go into an acute renal failure, say it's due to like injury to the kidneys or sepsis, and all of a sudden the kidneys shut down. They'll do emergency dialysis. When they do emergency dialysis, typically they're not creating a permanent fistula. They'll put a special catheter in. It's usually something called a Shiley catheter. So it's a temporary dialysis catheter that accesses the artery and the vein to let them do a temporary dialysis or an emergent dialysis. When they do the surgical creation of a fistula, that's more of a permanent thing for these patients that have the chronic renal failure. So typically they like to create a dialysis graft on the non-dominant arm. So if patient's right-handed, they'll do it on the left arm. If they're left-handed, they'll do it on the right arm. Again, we have to make sure that the vessels are an adequate diameter before we do it. So that's why we do our vein mapping. We also have to check that the inflow is free of obstruction or stenosis. So we check the artery that we're going to use to make sure that there's no blockages or calcifications. And we also have to check the veins and the outflow, you know, to make sure there's no clots, no DVT, make sure that both arterial and venous systems are open and flowing. And it's preferred to use a more distal location. So further down the arm, closer to the wrist is ideal, just because of the proximity of the artery to the vein. It makes the procedure much easier. And those veins are closer to the surface of the skin as well. So when they actually have to do dialysis, it's easier to access. So for hemodialysis, access placement of AVF is recommended for greater longevity and decreased incidence of infection. So this is saying, you know, they like, if they need to do long-term dialysis, they want to make this fistula as opposed to using just a dialysis catheter. So with a native AVF, they're using your native vessels as opposed to like a man-made graft made of synthetic material. So they'll surgically create a direct anastomosis between the artery and vein. This is for the process of dialysis. So and then they'll put a needle into 2 different segments in the graft. So you can kind of see here, blood gets shunted out, gets dialysized, goes to the dialysis machine, removes the waste, and then the blood flow is returned back into the body. So this is all done when patients' kidneys aren't functioning. So this is actually probably a more accurate picture, excuse me, for dialysis. So you have one catheter, they consider this the arterial needle, but it's still in that outflow vein. So down here is where the fistula is made. So arterial blood flow is going down the arm, hits this fistula where you have the connection between the artery and the vein. So it enters the vein and now starts going back up. So this would be considered the outflow vein portion of it, of the dialysis fistula. So this is where they're going to access. They're going to access the veins. So they'll put their one catheter in, go into the dialysis machine, remove the waste, and then the blood flow gets returned through the other catheter into the arm. So with ultrasound, when we're looking at these AVFs, one of the things we look for is maturity of the graft. So doctors, when they create this AVF, this fistula, it takes time for it to mature before they're able to use it for dialysis. So it could take, you know, it's usually about a month or so to mature. So what that means by maturing is that the veins now have to be able to accommodate this high flow volume. So you introduce this arterial blood flow into the veins kind of have to take time to kind of expand and become acclimated to now dealing with this arterial blood flow before they're able to hook them up to this, up to the dialysis machine. So the veins kind of have to get acclimated to being under now a high pressure system. The other things we use the ultrasound exams for is, you know, evaluate the graft to assess for stenosis or occlusion. So sometimes the grafts become occluded, we lose that thrill that we feel. So what I mean by thrill, like when you have that anastomosis, that connection between the 2 veins, the blood flow is moving so fast that you can really feel that where that connection is. It's a very unique feeling, that thrill. Hopefully after COVID, I want to get everyone down to the dialysis lab downstairs so you can at least, like, you know, feel what a thrill, you know, feels like, get a better appreciation of, like, you know, the process and what, you know, what a fistula looks like, because not everyone has seen one. It's also used for looking at perigraft masses, like evaluating if there's like a hematoma around the fistula or presence of a pseudoaneurysm. So types of dialysis grafts. So autogenous grafts using your own vessels. Most common one is a radial artery to cephalic vein shunt. So they like to do radial artery to cephalic vein. This is typically done down by the wrist if those vessels are adequate diameter at that level. You can also do an ulnar artery to basilic vein shunt. It's not as common. More common is this radial artery to cephalic vein shunt. You can also have synthetic grafts. So these are made of Gore-Tex or dacron grafts. So these can either be something called a loop graft, and we'll get a picture of that, or something called a straight graft. So with these synthetic grafts, we would do this if those vessels are, say, they're occluded, they have stenosis, or if they're not a good size, if they're too small, they don't meet the criteria for diameter. They would also use these synthetic grafts if they've had one of these like autogenous grafts. If they've failed, they may resort to using synthetic graft at that point. So this is just another chart showing some of the different connections that they could use. So forearm cephalic vein. So they would do radial to cephalic. So they can also do what's called a vein transposition. So they would actually move the ulnar vein over to connect to the radial artery. So they would like cut and ligate the ulnar vein and actually move it over slightly, like across the wrist, so it's closer to the radial vein and connected to the radial vein. In the upper arm, they'll typically do a brachial to cephalic vein, or they can do a brachial to basilic vein. Again, they'll transposition the basilic vein, move it over and connect it to the brachial vein. So the brachial to cephalic in the upper arm, typically you'll see that closer to the antecubital fossa. Same with the basilic transposition. You'll see these by the antecubital fossa. So then these are some of the loop grafts. So a forearm loop graft. So the brachial artery, it bifurcates just past the antecubital fossa, like in the proximal forearm. So with a forearm loop graft, it'll be brachial artery to brachial vein. I'm sorry, brachial artery to antecubital vein, I apologize. And then for a straight graft, they would do brachial artery. This is in the upper arm to the basilic vein. Or they can do an upper arm loop graft would be axillary artery to axillary vein. So this would be more in the upper arm. Or they can also do a thigh graft. Thigh grafts are pretty uncommon. You usually don't see it. The main reason being is that these grafts sometimes run a higher risk of infection, particularly if the patient's obese. The groin isn't the cleanest place in the world to put a graft. So if they're able to do the arms, it's much better, much easier access. So this is just a picture of your native vessels, the typical location that you're going to see that radiocephalic graft, the radial cephalic. So they make the anastomosis there, and then the cephalic vein becomes now the AVF where they're going to access and do their dialysis from. So that cephalic vein now is going to become big and dilated. So this is your typical image that you're going to see when you're doing your duplex exam. You'll have your arterial inflow coming down the arm. You'll have your anastomosis here. And then you'll have the artery distal to the anastomosis. So when I do my exam, I Doppler this radial artery coming down. So I'll Doppler proximal to the anastomosis, get my velocity, my waveform. and then I'll Doppler distal to the anastomosis. I'll check to see if there's any reversal of flow, if there's any steal going on. And then I'll proceed and do the anastomosis, Doppler, get my waveform, over here. It's critical to get the fastest velocities. So the doctors really care about, like, all right, how fast is this blood flow moving through that anastomosis? That's how they determine if there's a stenosis. So you're measuring the velocity there. And then I measure the outflow vein going back up. So we're Dopplering now the outflow vein. And we're getting our waveforms, measuring velocities, making sure that there's no blockage, no stenosis. So this shows ulnar artery to basilic vein here, and radial artery to cephalic vein. So this is straight grafts versus loop grafts. So loop graft, you have your artery. This is your proximal portion of your grafts, or arterial blood flow coming in, enters this man-made graft. So travels around the graft and connects back to the vein, typically around the same level. So the most common place you'll see them is kind of in this antecubital fossa going into the proximal forearm. So it'll connect to the brachial artery, loop back around to that median antecubital vein. There are a couple more examples of some loop grafts that you could potentially encounter. So brachial artery to cephalic vein. You can see this is a much longer loop graft, how far down it extends. These can be a little bit tricky to scan. Basically, you have to start, by trying to find your two anastomoses, and then figure out, which is the arterial side, which is the venous side, and then scan down the artery, and then I like to go in transverse and just kind of track it in transverse, and then reorient myself in long and take my Doppler, my 2D, my color, my Doppler, my waveforms, measure my velocities, and proceed down the graft. This is a brachial artery to basilic vein graft. This shows a loop graft that a patient could potentially have in the chest. I actually encountered one of these. It was a little interesting. I'd never seen one before. You can actually feel it, like you put your hand down on his chest, you could feel the anastomosis, or that thrill, where it connects. So this is subclavian vein to, axillary artery to subclavian vein. So these now are the straight grafts. So here you can see it connecting to the brachial artery, running up the upper arm, and it connects to the jugular vein. So with these grafts, it's important for us to remember that there's going to be two connection sites, or two anastomoses. So you'll have the arterial or proximal anastomosis, and you'll have a distal anastomosis, or a venous anastomosis, where it connects to the vein. So it's really critical when you're assessing a graft that you image it in its entirety, and particularly visualize the two anastomoses, those two connection points, because that's going to be where you develop your blockages or your narrowing or your stenoses. Then here you have brachial artery to subclavian vein, straight graft. Some more examples of some grafts. So down here, you can actually see that basilic transposition. So normally the basilic vein would run down, along the medial aspect of the arm. You actually move the basilic vein, and it's called the basilic vein transposition, and move it over to this side, more superficial, make it easier to access, bring it closer to the surface of the skin, and connect it to the artery there. So that's called, that would be an example of your basilic transposition. So this would be the thigh AVF, which is, you can see, a loop graft. So this is a good example of what a synthetic or those man-made grafts look like. So this is your double wall Gore-Tex graft. So this is probably the most common graft that you'll encounter. So you'll see kind of the telltale sign, this double echogenic lumen. Like you can kind of tell like this isn't natural. And you can see every so often these little echogenic rivets too. When you're in transverse, you can appreciate these circles. Like you'll see them going all around the graft in a circle. So you'll have your double echogenic lumen and these little bright echogenic dots around the periphery if you're in transverse as well. And then this is also another synthetic graft, a Dacron graft. So you can see you get these like this wavy surface to it, kind of like a striated appearance too. This one, you might actually be able to see kind of like a mesh like appearance to it as well. So again, for placement, we want to go into the non-dominant arm. So this is some of the grading criteria for diameter. I see here Lily put 0.25 for the veins. I always go with 0.3. I mean, if we round 0.25 up, it rounds to 0.3. Some machines might not even like give you out to that decimal place. So it's just a general rule of thumb. I like to go 0.3. Some of the textbooks go 0.3. I think the registry goes 0.3. So this might be an older chart. Yeah, 1998. So if we're gonna do a graft, one of those man-made grafts, you need the vessel a little bit larger to be able to attach that to. So this is all gonna be in your vein mapping measurements. So, they'll have all your measurements. They'll be able to see what the diameter of the vessels are. So the surgeons then can make the determination, if the vessels meet that criteria for doing a regular AVF, using your native vessels, or if they need to use the graft. And then for the artery, you need a diameter of at least 2 millimeters or 0.2 centimeters. So 3 millimeters, 4 millimeters, and 2 millimeters. So physiological changes of hemodialysis graft. So in that proximal artery, you're going to have increased in flow. So you're going to get increased velocities. The flow, you're going to get a decreased resistance. So it's going to be low resistant, high velocity, high diastolic component to that arterial flow. You'll have increased venous outflow. Distal or beyond that anastomosis, you're going to have decreased arterial flow. So the waveform is definitely going to be much smaller. You usually see a return back to a high resistant waveform, the normal arterial waveform. You can also see a steal phenomenon. So that's that retrograde flow that you might see within the artery beyond the anastomosis. So the venous anastomotic site is a common site for plaque and stenosis to develop. So when we're scanning these grafts, we're evaluating the patency of the graft. Oftentimes we'll get patients that come to the hospital and we have to do these hemodialysis graft scans. One of the main indications is that they lose that thrill. So the dialysis nurse or the doctor, they no longer feel that palpable thrill. So that's a good indication that the graft has failed, that it's now either thrombosed or clotted, or there's a stenosis somewhere along that graft. Other indications could be if they go to dialysis and the nurse has a difficult time with the needle placement, if the pressures are elevated, because their dialysis machine also measures pressures within the vessel. So if they get abnormal pressures, if there's any sort of swelling, abnormal swelling, if it looks aneurysmal, they may send us in, you know. If there's any sort of palpable or focal mass around the graft, you know, could indicate a hematoma or a pseudoaneurysm, abnormal lab values, arterial insufficiency. So if the patient now has been doing dialysis for a little while, or if they created the AV fistula and all of a sudden the patient's hand starts turning blue, becomes cyanotic, or they have a lot of pain in their hand or their, you know, distal extremities, it could be an indication that now you have an arterial steal, you know, that blood flow is not getting down to the hand. So that could be another potential indication that we do a duplex scan. So there's no real preparation for the exam. Patients lying supine with the arm abducted. The same way we're doing our venous scans or normal arterial scans, you know, you usually place the arm over you. So when you're doing it, you also want to, you know, assess the arm, you know, get the patient's medical history, find out what's going on, find out if it's a graft versus an actual fistula, you know, if it's just they use their normal arteries and veins, or if they actually implanted a graft. And then also palpate for that thrill, because when you palpate for that thrill, that's going to be your starting point. It'll give you a good idea of where that anastomosis is and where to begin scanning. So again, you're going to evaluate that inflow artery. You're going to image that arterial anastomosis, that connection. You're going to image the body of the graft. So if it's a man-made graft, you're going to image, you know, proximal graft, mid-graft, and distal graft, but you're going to scan all the way through. But usually it's going to be about 3 representative images. You're going to image that venous anastomosis where it connects to the vein, and also the outflow vein. So you're going to continue after that, after the venous connection, and image the outflow vein to ensure that there's no thrombus or blockage. So graft stenosis usually occurs due to a process called intimal hyperplasia. So this is thickening of that intimal layers. So it becomes thickened, and then that opening then becomes narrow. This is most commonly located at the venous anastomosis. So interpretation, velocities are normally elevated, may have spectral broadening. So low flow isn't maybe an indicator of graft failure. So the new thing now is we actually measure flow volumes within the grafts, within the fistulas. I think Lily has a couple slides later on that actually show how we calculate flow volumes. Thankfully, it's a calculation that the machine does for us, so we don't necessarily have to do any math in our heads or anything like that, or memorize any formulas. So velocity, peak systolic velocity ratio is calculated at the anastomosis and at any stenosis, sorry. So if peak systolic velocity ratio is greater than 2, it means that's a 50% diameter reduction. If the peak systolic velocity ratio is greater than 3, it can indicate a 75% stenosis. So we get this ratio by taking the velocity that we get immediately in the artery immediately before the anastomosis, and then we compare it to the velocities that we get within the graft at the anastomosis and at the graft, through the graft. So this is a normal dialysis graft flow. So this is now after the anastomosis, so we're in the graft, and we now get this mixing of arterial and venous waveforms. So this would be considered mixed flow. And this tracing that's actually above the graft is a function of the ultrasound machine. So you'll set your caliper at, just beginning of systole here and end diastole, and it'll actually trace the waveform. And this, in combination with measuring the diameter of the vessel at that point where you're sampling, will calculate a flow volume for you. So that's something that the machines do now. So a lot of the vascular surgeons or the dialysis doctors, the kidney doctors, they'll be interested in what's the flow volume through the graft, and able to determine if the graft is now mature and they're able to use it for dialysis. So they try and calculate flow volumes. So basically what you do is you just measure the diameter of the graft at that point where you're sampling, and then use the function of the ultrasound machine, which will trace, the flow pattern, and it'll, based on those two measurements, will calculate a flow volume for you. This is just talking about assessment for basically the vein mapping process. It talks about placing a tourniquet. I've never placed a tourniquet when doing a vein mapping. I'm not sure if any of the labs here necessarily do that as well, but I personally have never seen placing a tourniquet. Again, it talks about the artery needs to be at least 2 millimeters, and go with 3 millimeters for the veins, and up to 4 millimeters if they want to do the graft. So when we're doing a vein mapping, we don't place a tourniquet. We just scan the vessels normally. So this is actually a good picture showing the proximity of the radial artery to the cephalic vein down by the wrist. You can see just how close it is, how close they are to each other. So you have your cephalic artery and the two cephalic veins. And then, I'm sorry, apologies, radial artery, two radial veins, and then the cephalic vein over here. So you can see the proximity between the cephalic vein and the radial artery. So this would be a measurement of 2.4 centimeters, which is suitable. And you can see a normal arterial waveform. So that's indicative, you know, that there's good blood flow getting down, that there's no stenosis. This is normal cephalic vein at the wrist. You know, it's nice, good diameter, normal depth. All right. So this is more for assessment for hemodialysis access for the upper arms. So they'll do the bacillic transposition if no suitable cephalic vein is found. So the bacillic transposition, when they move that bacillic vein, it's more of an invasive procedure. So if they can avoid that, they will try to. Again, we're just, you know, confirming patency of the deep system and the superficial systems, measuring our diameters and our depths. Your normal brachial artery. So this is a small cephalic vein. You can see the diameter is 1.4 millimeters. So that doesn't meet our criteria. So subclavian, internal, and central vein assessment. So this is when we're looking at the deep veins now. So to ensure that there's no indication of any sort of stenosis or blockage, we want to evaluate the patency. We look for, you know, respiratory phasicity and cardiac pulsatility. So if we have a monophasic waveform in the medial subclavian vein, or in like the lower portion of the jugular vein, central stenosis or obstruction could be a possibility. So those veins may not necessarily be a good option on that side, because now we have something that could be a stricture or a blockage or some sort of obstruction proximally. So if flow abnormality is unilateral, it could potentially be an issue with the brachiocephalic vein. If blood flow is abnormal bilaterally, it's more central. So we're talking more the superior vena cava, a stenosis in the SVC. So monophasic flow may be seen in subclavian artery in the presence of an upper extremity graft without central stenosis. So we may lose, like again, we may lose that triphasic waveform within the peripheral arteries and may become more monophasic because we now made that connection with the venous system. So here's your normal subclavian vein. When we're imaging, we get very pulsatile flow. So here shows a normal right subclavian vein waveform, then more of an abnormal one when we compare the two. And then they did a venogram showing a left brachiocephalic occlusion. So you can see, like, if we do our waveforms, whenever, that's another thing I forgot to mention about the upper extremity venous DVT studies. When we're doing an upper extremity DVT study, we always image the contralateral subclavian vein as part of the study. The reason for that is to compare these two waveforms. We want to see a similar waveform in both subclavian veins, because if we don't, it can indicate a more central thrombus that we're not seeing. So then in this instance, it was a brachiocephalic occlusion. So this shows heterogeneous thrombus within the left internal jugular vein. So this is the lateral aspect of the subclavian vein. So out closer to the shoulder, you can see this monophasic waveform. So that's not your normal subclavian waveform. It's not pulsatile. So this would probably indicate that there's thrombus within the jugular vein extending down into those central veins. So potentially the brachiocephalic vein, or even the superior vena cava. So AVF maturity assessment. So this is when we're measuring those flow volumes. So a flow volume suitable for hemodialysis is between 300 and 350 cc's per minute. So when we're doing our measurements, we're going to measure the diameter of the vessel. So we want a diameter greater than 4 millimeters and a flow volume greater than 500 mLs per minute. So that if we get over 500, that graft it's mature in 95% of the cases. So usually when we see 500 ml per minute, the surgeons know, all right, we're good to go. This graft is matured. So after the anastomosis has been made, the veins, become very dilated. So this is an image of the cephalic vein. It measures 1.1 centimeters, 11 millimeters. So here you could see a large drainage branch. Sometimes you can get branches off these vessels. These large drainage branches sometimes can hinder or slow the progression of maturity for the native vessel. So this is the cephalic vein, the native cephalic vein. And then this would be a branch coming off of it that's now becoming dilated. So that's why it's important when we're doing these vein mappings to note any branches, because these branches can sometimes hinder dialysis, make it more difficult, and slow the maturity of the native vessel as well. So arterial steal in AVF. So a lot of this depends on the patient's symptoms. Are they having hand pain? Is there numbness in the hand? Discoloration? Are the fingers turning blue? Do you see cyanosis of the digits? So then we're going to evaluate the artery distal to that anastomosis where that connection is made. So a complete arterial steal, you'll see a complete reversal of flow. You may also get a biphasic waveform or a partial steal, meaning you can have a systolic component, that's antegrade going down the arm, and then you get flow reversal during diastole. So that could be a partial steal. It's not uncommon to see a steal immediately after that anastomosis. I actually kind of remember that on my registry as being a question. They showed like Dopplering just distal to the anastomosis and showed a little reversal, which can be normal. So an asymptomatic arterial steal is relatively common and present with no clinical significance. So you can get a small arterial steal as long as the patient doesn't have any symptoms. That could be a normal thing. Severely symptomatic patients may require that the graft be ligated. They may actually have to close off that graft to correct the steal. So this is a Doppler waveform of the inflow artery, the feeding artery with normal arterial waveform. So again, it's high velocity with low resistant flow. And then at the anastomosis, you get those elevated peak systolic velocities. So we can also use PPG to assess for steal syndrome with these fistulas. So we can place a PPG sensor on the fifth digit or the fifth and the second digit. Try and get two waveforms, Sometimes I do the fifth and the first, but you can also do fifth and the second. And then we'll do a compression maneuver to gently compress the graft. So we'll apply the PPG sensors. We'll get a baseline waveform. So this is the right digit, and then this is the left digit, second digit. And then we'll compress the graft and see if we get a return back to or improvement of flow after compression of the graft. So then we can, using the PPG, tell that it's the graft that's causing, the reduction of the flow down to the hand and not just, arterial disease. So this is just some pictures showing some color aliasing at the venous anastomosis with the turbulent flow and peak systolic velocities of over 400. So this would be considered a stenosis because if we look at the ratio that we're getting, we see an increase of about 4 times. So this is a good picture of what you typically see with a radial cephalic AVF. So this would be your radial artery, your inflow artery. So the artery's coming down the arm, you get your anastomosis. So this is the picture that you're really trying to get. So this is the Dopplering that anastomosis there. And then the vein now with the turbulent flow going back up the arm. So this is now probably most likely the cephalic vein going back up the arm. So I would Doppler the radial artery proximal to it. And then I would also try and see the artery extending down the arm this way. So I'd Doppler the radial artery distal to that anastomosis, get my waveform. Then I would go back, Doppler the anastomosis, the connection, get your fastest velocity. And then I would begin Dopplering proximal, like to the anastomosis here, and we'll just work my way up the vein, up the graft. So some of the things that we look for when we're doing it, we're searching for any sign of aneurysm. We're looking for puncture site leaks, pseudoaneurysms, any fluid collections or hematomas around the graft. We're looking for velocity increases, turbulence, flow changes, any flow changes, any signs of stenosis. We're looking for thrombosis, clotting of that graft, any wall thickening or plaque. Some limitations that we might encounter, it could be limited access. They could have bandages over the area. They may have just had dialysis, or they could potentially have just had the procedure to create the AVF. So there could be staples in the area, incisional tenderness. There could be a large hematoma in the area and swelling that could limit imaging. Obesity, if they have a large arm, could be difficult. Shadowing from calcified arteries. So this kind of just goes over the protocol for dialysis graft imaging. So it's kind of similar to the way we do an arterial exam. We're in transverse and longitudinal scan planes, image the inflow artery, entire length of the graft, and the outflow veins, all in long and transverse. Velocity and volume measurements are taken at the anastomotic sites along the graft. So I do prox graft, mid graft, distal graft at any puncture sites. We measure velocities at any obvious areas where you see like the vessel diameter becomes smaller. So any obvious lumen reductions. So this is a chart showing some of the velocity criteria that are used for grading stenosis. So this is within the graft. We want velocities greater than 150 centimeters per second. So you notice the velocities start dropping if you have a stenosis within the graft. Typically the stenosis is at the anastomotic sites, like at the connections. So when you have stenosis at the connections, the flow within the graft starts to diminish. So you start getting these reduced velocities. So you have a stricture either at the beginning or at the end. It's going to start slowing the flow within the graft. So that's the important part that you really kind of want to look at, is what you're getting within the graft. Um, I know in terms of the registry, they don't really ask you velocities for graphs. That's not really something that they're going to question you on. I guess it's more understanding like the graphs themselves, like why we use them, the different types of graphs, the diameter criteria for the graphs, and recognizing, you know, basically what a waveform looks like what a fistula waveform looks like, you know, being able to be like, oh, that's probably like, that's a normal waveform for a dialysis graft or a dialysis fistula, you know. I apologize about the not having my video working. I'm just kind of like a voice from heaven. Does anyone have any questions about anything? Like anything you want me to go over again? I know like with the DMS girls, I had mentioned like ovarian flow, like these AVFs that can be created within the uterus after a C-section. So with those, you'll put your color on the uterus and you'll notice all of a sudden, oh my gosh, it lights up, and you'll actually see the veins within the uterus like dilated. So you may see like little circles, like anechoic circles. And those are the veins that are now become very dilated because they now are filled with arterial flow. I'm gonna see, maybe we can find a picture of that. And when you Doppler these vessels, you're going to get high velocity, low resistant flow. So that can start raising red flags, you know, like, all right, this patient may have, you know, like an arteriovenous malformation in the uterus or an AVF in the uterus, you know, that's a result of this C-section. Let's see, I can find one. Yeah, so here you can see what it looks like when you put your color box on. All of a sudden you get all this turbulent flow, all this color. And when you Doppler, you know, you're getting, let's see, let's get that one. So you're getting, you know, those very turbulent flows that look very similar to what you see when you have a fistula in the arm. You know, this spectral broadening, high velocity, high diastolic component. So AVFs, or these AV fistulas, can be created, you know, in the uterus as well. Little caveat with this too is sometimes this could look like retained products. So when we do retained products at conception, you know, we're putting color on the endometrium. We're looking for any sign of like vascularity. If it's severe retained products at conception, you can actually wind up with increased vascularity within the myometrium as well, the muscular layer of the uterus. But when we Doppler, the velocities aren't going to be as high. So with true AV fistula, you're going to have very fast velocities. With retained products, you'll still have, low resistant flow. So you get a low resistant waveform, but the velocities aren't going to be anywhere near as high as with an AVM or an AVF within the uterus. So normal uterine arterial flow is a high resistance waveform within the uterus. The ovaries is nice low resistant flow, but within the uterus, you should get a high resistant flow, arterial waveform. So this was, for this patient, this wasn't even like a C-section. This was following a DNC that they created that this happened. You can see the anechoic spaces adjacent to the myometrium there. So that's blood flow. Those are dilated vessels. Any questions for anyone? No? All right. So in terms of the competency, I was talking with Kathy. So we're going to start with one person at a time. So I was going to have like one person, scan. You can use whatever machine you'd like, whatever you feel most comfortable with. And I was going to have the rest of the students like have you report for your normal scan times. And the rest of the students will be like your patient population. So you can pick, whichever patient you want to do it on. So I'm not going to assign you a patient. So I know Lily was pretty hardcore with that. Like, this is who you get and this is the machine you have to use. And so I'm not going to do any of that. So like you come in during your normal time and then, you can pick the patient that you wanted to comp on. And, depending on how it goes, I might be able to do 2 people at a time, but Kathy told me just, focus on the one person, but treat it kind of like a real life scenario, you go out to the waiting room, like identify your patient, bring them in, explain the exam, get some history from them, why we're doing the exam, what's going on, and then proceed, because all that is part of the grade.
Do we have to use somebody from our lab time? Like, if I'm willing to go in like for somebody in the afternoon, or they're willing to come in for me in the morning?
Sure. Yeah, okay. If they want to. Yeah, it's fine. Yeah, definitely. All right. So I guess if no one has any questions about, fistulas and any of these procedures, and that's it for the day. I apologize that, again, my video is not working. I'm just kind of trying to do this from home.
It's okay.
Quick question.
Sure.
For the quiz next week, it's just going to be based on the last 2 lectures that we did this week and last week?
Yep.
Okay.
Thanks, Dan.
You're welcome. All right. So that's it then.
Okay. Thank you.
Yeah.
Great.
For the rest of your day, I'll see you.
Thank you.
Welcome.
Thanks. Bye.
Bye.
Thank you. We'll see you.
See you.